that those two are parallel. So I can just move myself around on the other side of this. If A is parallel to B and B is parallel to C, then A and C are parallel. That's the only thing I remember from the math course I took. And we can see here these are in the same orientation, and we can just work our way on around. If I didn't like where I was, I could go ahead and choose another osteotomy site in this area, because I know in this area I'm away from the foramen, and then I can revert back to using my fingers to determine the outline of the buccal and lingual outline of fines of the mandible in this area, and I could simply go in and place another osteotomy. So you don't have to beat yourself to death if in fact you find that you may have not placed it parallel, or you have the option, as I said earlier, to go with angle-corrected implant, and it's no big deal to place a 5-degree correction in there. I would say if you have to study it, it's most likely within that 5 to 8 degree range that it's not going to be a problem. If you ever place in the mannequin a 5-degree correction, it's easily seen that they aren't parallel. So again, you don't have to spend 20 minutes deciding, am I there or not? If you can't determine that with a quick look, then most likely you're within that range. What we've done is now we've taken the 1.6 guides out and placed the 2.4 guide in only in the areas that we're going to be using. You see I've removed the 1.6 in the other areas because I want nothing to happen that it'd be impossible to go into the osteotomy in the wrong position, so therefore I would be too large for a 2.2 implant. So basically I feel that we've gotten where we need to be. We may have to tap, but we'll determine that after we go to the next step. Again, we're going to reposition this right where we were before and take our osteotomy to depth. If this were type 2, 3, or 4 bone, we may not go to depth, because then we, as you're going to see on the upper, we would allow the implant to be our tap, which would condense the bone like a sponge, and therefore the bone around the implant interface would be much denser than the bone in the rest of the maxilla. All right, so now we're going to go with our 1.6. Let's do this. Let's take it out one more time. It's important that you make sure those are locked in place. If they don't, your inserts, what will happen is that they'll move on you when you start your burr. Neat thing is that they've even labeled a 2.4 insert tool, which makes it easy for you, if you've never used this system, to go ahead and use the proper tool and not get frustrated because you have to go through a range. The system is built for placing just about any implant that you so desire. In this case, it's the ERA. And I think you can readily see that how nice it is to have these securing pins, because I've taken this out now a couple of times. It might be a little more challenging to make sure I've repositioned it, although in her case it seems fairly easy to do. The accuracy of this is such that I can get within 0.2 of a millimeter of where I want to be, provided I place it in the same position each time. And I would like to think I was good enough to do that, but 0.2 of a millimeter isn't a whole lot of variation. Also with the system, it takes into account the soft tissue. The other systems that are out there, the other type of CT scannings, will go ahead and make a hard copy, a model of the bone, but they don't tell you the compressibility of the tissue. So if you have extremely compressible tissue and that moves maybe 2 millimeters, you can readily see that now you have a 2 millimeter error in your guide. So with this system, since it was taken, the CT scan was taken with the same appliance that is now the CT or surgical guide, the tissue is compressed equally both times. And because you did the treatment plan, you know where to expect the bone to be much more dense, and therefore with this With this guide, I may have to go up and down just a little bit to allow my burr to be more efficient with the cutting. But I know that when I do that, I'm still going to have a stabilized osteotomy site. Now I'm going at 1800 RPM and 55 Newton centimeters of torque. Okay. Now we'll remove this. I'm going to do one more thing with our guide in that I couldn't do freehand. I'm going to go in and use our countersink, and that's really kind of a misnomer. It's not a countersink. It just flattens the bone and creates a site for our abutment on our implant, female abutment, to rest. We've predetermined already that we have adequate width of bone at the occlusal surface, so I'm not going to go in and take any more bone off. Which is another point. If I have an area where I could put, say, a 4.0 or a 5.0 implant, but in order to do that, I'm going to have to take a centimeter of bone away because at the occlusal interface, it's too narrow. In my mind, it makes more sense to save the bone and place a smaller diameter implant that is sufficiently long rather than place a wider implant and have to reduce the amount of bone necessary for the implant to be in between the buccal and lingual plate. Go ahead, our insertion pins again. Now, what you can do here, if we've determined that we have adequate amount of attached tissue, which we did with our blue markers, the marker was inside of the confines of the buccal and lingual attachment, so this makes life a little easier for us. We can go now with our countersink, which will fit right in the surgical guide, and it again is stabilized, so I'm not worried about it going back and forth. I think you can see with the ILS system, this is the countersink that has the stop on it that'll let me go into that bony interface and flatten it exactly where I want to be, and that was predetermined into the treatment plan, which makes it a little easier and a little more efficient to get where we want to go. Now, if you notice, this is the countersink with the 1.6 burr. So I went into all the sites with the 1.6 countersink, and I may have to go back in with the 2.4 countersink, which is what we would use for the larger implants. So you can see here, I think readily, that we're getting close to our attachment here, so I may make a slight incision here to protect the buccal aspect of our attachment, just so that we can go ahead in this specific site, the midline site, so that we can maintain our attached tissue. Everywhere else, you can see that we have adequate attached tissue, and we won't need to go and do that. So we'll use our tissue punch in just a second, but right now I'm going to make the incision. We have a laser. You can use the laser, or you can actually use whatever you normally use. The laser makes it easier, but for purposes here, I'm just going to make this incision mid-crestal. And I don't have a problem going beyond the mucogingival junction, but if you don't have to, why? So now I'll get my tissue punch. The one I'm using is a 4mm tissue punch, which will be a little bit broader than our 3.4 abutment. This is the tissue punch that we'll be using. And we'll have our patient open real big. Now you see I move that facial aspect of that tissue facially so my tissue punch will not affect it, but it will clear the area that we need to be cleared. It's not a problem actually to lay a flap. I have no problem with it. However, if we don't need to, then it's easier on the patient and fewer post-operative visits. When you're having to make or place a flap or crestal incision and reflect the tissue, in many cases you'll find that it's extremely bound to the bone, and you need to be very careful reflecting your flap, or you'll tear the tissue, and then that just makes more of a challenge when you start to suture the patient back. If you have an implant that you're going to, that's a conventional implant that you're going to place in the ERA abutment, they come in cuff heights. The implant itself, the ERA implant, has the part of female attached, or is incorporated in the implant itself. They come in cuff heights, 1, 2, 3, and 4. Doing a lot of replacement or refitting of the bar retained overdentures, because the bar retained overdenture was mainly there because there was not an attachment. It would alter for angle correction, so that's why the bars were used in overdentures. However, what that does is provides us with a implant-supported, implant-retained prosthesis. Not only that, it elevates the rotation point anywhere from 8 to 10 millimeters above crestal bone. So when you look at it, we have a situation where we are now doing everything we can to displace adverse forces on the implant. So what we're doing now with this is we're taking the bars off, reducing height, reducing tissue if necessary, and then refitting the existing implants with either an ERA abutment or placing ERA implants to lower those rotational forces. Now I'm going to go back and just make sure that I'm at the depth I want to be. And in your kit you have a 1.6 burr that it has the lines on, and it has lines from 8 to 15 millimeters. It's easier to see these lines when it's rotating, and you can see the lines a little bit easier than if I have it stationary. And since we're at 15 millimeters, we're going to go to I'm just going to go back down in those areas just to verify I'm at length in this bone, because the 2.2 implant will still have to tap itself. We're going to go on our most distal implant after I go to the depth and make sure we're at 15 millimeters. I'm going to go to the most distal implant and try to place the implant. If I can get it within 2 millimeters with finger pressure, then I can go ahead and use my wrench. If I can't, that means that implant is not able to tap the remaining portion of the bone, or osteotomy. So what we have to do is go back and enlarge the osteotomy, or another way of looking at it is make the bone less dense in that area so that we can get our implant seated with 35 newtons centimeter pressure or less, but keeping in mind we want it stable. So now we're comfortable with what we've got. We're to depth. We've gone in 2 areas at 1.6 burr to 15 millimeters. And the other 3 areas we've gone to depth with a 2.4 millimeter implant to our 15 millimeter depth. Now we'll place our implant, or attempt to place our implant. If I can get it within 2 millimeters, then I know I'm good to go. But I won't completely seat it. I'm going to put all the implants in place, because a lot of times you can actually expand the bone, more so in the upper, but sometimes in the lower if you sequentially put them in. So you look back on your sheet, you know that to verify, it's always good to have more than one eye reading that. So I read it, the assistants read it, it's red, green, or blue, so we're all in agreement that's what we want, because if I go with the wrong size burr, I've oversized my osteotomy simply because I didn't pay attention. Someone there, it's a double check. What happens if it's too big? Well, you either place a larger implant or move your osteotomy one way or another. Now you say, well, you've just destroyed your stent. That's true, but if you know where because you treatment planned this, if you're going to go mesial to the last implant for the osteotomy slightly, then you know you're not going to be in an area of concern. And don't forget, many times you're going to be placing these freehand, and your fingers are going to be your determining factor. What does that mean? That means one's finger is on the most buccal undercut, and one finger's on the most lingual undercut. And your goal is to not puncture your finger with the burr. So if you're splitting the difference, that's a good way of doing it. Also, you'll be able to feel since the tissue is covered in many cases, you'll be able to feel if the burr is actually outside bone, because it will vibrate on the finger in that area. What happens if that happens? You simply take it back out and reorient it in a position that you don't feel that sensation. This is a 325 by 15, and you'll see the etch goes all the way to the base of the abutment. And so with the countersink, what you're doing basically is preparing the osteotomy to allow this to seat to that level, which is exactly 3.25 millimeters. You want to seat the silver portion or the etched portion into bone and keep the gold portion or the cuff height above bone, right? And this is 1 millimeter base from the silver portion or the etched portion to the top of the hex there. And this is a very aggressive thread design, so why am I telling you that? With a lot of force, you could actually create a new osteotomy. Now, I'm not strong enough to do that, but I have 2 assistants that could easily do that. So therefore, you want to make sure that you're not going in an area that wasn't prepared. And it should have, in this type of bone, I should feel that it's starting to engage, because at this point, we're still driving a 3.25 implant into a 2.5 or 2.4 hole. And if we use the tap is going to be the same diameter of this implant. It just creates the thread so that it may be easier to place. So I get to about this point, and I can still go with my fingers, but I want to use my torque limitation handpiece to show you a different way of doing it. Once you have it positioned in the mouth, you can go ahead then and reduce your torque to about 35, 40 Newton centimeters. And when it stops, if I'm not within a millimeter or 2 of seating, then what do? I take it out and tap, and I may not tap all the way down. What I'm doing is placing this driver so that it engages the hex. I don't want to start the motor till I know I'm engaged in the hex, because if I do, I will round out the hex, and then it will make it a little more challenging to get my instruments to be of use in driving this into place. And you see we're going to very slow, and I'll have my assistant intermittently inject some water in this area, or some saline, since we want to keep it cool. I don't want to have it coming on as strong as I did before, because if I do, right there, what happens there is the patient ends up drowning. Okay, now there's where we are. You can see we're not close to being seated yet, but we're within about 2 millimeters of being completely seated. So I'm going to go and use my wrench with the handpiece. I can't feel what I'm doing. With this, I can feel the bone expanding, for instance. I can feel that if it's getting to a point that I may want to bring it back out and use something else. Now, here's 2 types of drivers. This is the one that was originally in the kit, and you can see it's got a longer arm. Longer arm means that you are able to place more force. More force means that you may be going beyond the biological limits of what the bone will take, and therefore you may seat the implant, but you might have pressure necrosis in that area. So those people of wisdom at Stern Gold came up with a shorter one, so that if you're Hercules, you're going to create a lot of force. With a shorter arm, it's with finger pressure, and it's very doubtful you'll get close to that 40 Newton centimeters with just your finger. So this is one, you weren't shorted when you got this one. This is the one that you want, not the other one. Why did I not tap? Because I'm experimenting, if you will, or deciding what protocol I'm going to use in this particular bone. If I can't get this to place with the proper amount of force, then, or get it seated, I'm going to remove the implant, and then I'll tap. And what I'm doing is making the bone in that area less dense, so that I'll be able to place the implant with the appropriate amount of force. I may go in and tap halfway. And if I still can't see it, then I come back and tap it all the way. Once I find the sequence on this side, chances are I'm going to use the same sequence all throughout. And so I'm still with finger pressure able to drive this in place. So therefore, if I would have tapped this, I may have made my osteotomy just a little bit too loose, or I would have created a type 3 or type 4 bone situation in a type 1 bone area, which means that I want to be able to have this implant do the tapping, which also is translated to mean that the less distance the bone has to grow, the more secure the implant will be in a shorter amount of time. In the mandible, in this type of bone, I have no problem loading these in about 3 months. In the maxilla, I'm still old school. I like 4 months of time, simply because if they've gone 15 or 20 years or more without retention, without stability, 4 more months, in my mind, is going to add added security. And it starts getting a little tight. What I'm going to do is stop here. And if it's turning but not rotating, see, that was turning, but it didn't seem to go into the bone anymore. What would that mean? Well, that would mean probably I'm engaging that extremely dense cortical plate right at that area. And it probably would also mean that this implant is not able to engage it. So what would I do? Would I use a smaller implant, or would I go and with my 1.6 burr and engage that cortical plate so that now I have a purchase for this implant to go a little further down? And the answer that I use is the second. So I'm going to take this implant out and go, and on our treatment plan, we knew that the cortical plate in that area was up to 1,500 Huntsville units, which is type 1 plus bone, very, very dense. And in a couple areas we're going to be where we're right at that limitation. So what I'm going to do is remove this implant, go with my 1.6 burr just about 1 millimeter so that I can engage it, because I'm not quite seated all the way, and I'm turning, but I'm no longer engaging. If I continue to do this, I'll strip the area, and then my implant won't be as secure as I want it to be. So remember, what happens here will most likely happen elsewhere. So I'm going to probably go back and see if I can engage the cortical plate on those others. Although I was right at 15 millimeters, it was too dense to engage that last ½ millimeter bone. So we'll go ahead and take this out. Those that haven't used the system, the arrows tell you where to go. And we want to arrow away. That means we're going to remove it and go back in and tap that area. Not tap it, but tap that cortical plate of bone. And you want to, with this, you want to make sure that this is a hex. It seats on that abutment. If it doesn't, then you need to reposition it till you feel it fall down over the abutment. And when you feel that, just like we did with a driver on the hand, you see now it's seated. And I can bring this up just a bit. Now, I could have left that there, probably been fine. I'm real anal about this kind of stuff. If it's a ½ millimeter, I'm going to take it a ½ millimeter further. We have a 15 millimeter implant here. I don't think that'd be a problem, but I want that abutment to be seated on the crestal bone, and it was about a ½ millimeter off the crestal bone, which would probably allow for tissue undergrowth, which would also make it more of a challenge for our patient to maintain this implant. We'll place this back on and take it all the way out. Some of you are saying, well, that's awfully snug. What are you trying to do? Again, I'm trying to make sure the abutment seats completely on the bone. So I'm probably going just a little beyond 15 millimeters because that's right where this is tapping. It's right where it's stopping. Are we going to go with a lot of force? We're going to go a millimeter, a ½ millimeter at most. This is a 1 to 70 or 1 to 16 reduction handpiece. And you see I didn't go very much. It was just a little bit, but that little bit will probably allow us then to engage it. I want to make sure this is what was adequate and it gets me to where I want to go so that I know how much I'm going to have to go down on the other osteotomies. Remember, I haven't tapped yet, so I've ruled one step out, and I'm ruling that step out not for any other reason, but to make sure that I don't need to do it. If I need to do it, I will. And I can see it, now it's engaging that last little bit of bone. And as you can see, it's slightly subgingival from where it was before, 0.5 millimeter. So did I need to do it? In my opinion, I probably did. Well, I would do it anyway. So now, as I was so kindly reminded, I'm going to go down and do the same thing on these others so that I can get rid of the use of that 1.6 burr. And here, I'm not to the cortical plate there. I'm slightly superior to it. So I'm not going to turn the motor on at 325 site to create any more depth because I don't need to. For those that haven't done many implants, and excuse me if those that are looking at this say, I knew that. I don't know who knows what. But sometimes you'll get in this area and it will bleed quite profusely to a point that you think you've done something wrong. How do you stop that from bleeding? You either place the implant or place a paralleling guide and it will stop. Also, when you're looking at reflecting a flap, it may bleed quite profusely. Once you get the periosteum pushed away, it stops. So remember, you want to get to that point as quick as you can. Why am I placing my primary implants first? Because they're going to expand the bone a little bit. When I place a 2.2, it's going to be pretty snug. I prefer not to tap that if I don't have to. So if I've expanded that bone, that may preclude me from having to go back in and tap in that specific site. Now I'm pretty certain that I won't need to be going back in, so I'm going to place all these with my finger wrench until I can't go anymore. I want to very gently push my tissue back here so that I can make sure that I'm not damaging my attached tissue. You see, we've pushed that attached tissue facially, so we're not trapping it underneath our implant. Remember, we made a little mini incision here so that we're going to make sure that we're in the right position. And our tissue is now no longer under the abutment, which is almost seated, but yet the tissue is now coming over the facial surfaces, which is what we want. I try to make sure as I'm going to place that I have the tissue facial to the abutment as it's going down. Now we're going to go with our 2.2s, not completely seat them, but we're getting them in position. As you're placing these, again, position your finger facial to the bone, and if you can, lingual, to make sure that you don't feel any threads. Although you've gone with a scan, it doesn't hurt to double check things because we are very thin in bone in this area. Since we did a punch technique, we minimally reduced the tissue, and that's not a problem as long as you make sure, again, as you're going to place, that you're not trapping the tissue as you seat. As you remove your driver here, you don't want to rock it back and forth, especially unless you've stabilized it, because that is a very small implant. It's extremely critical if you diagnose that you're going to be thin bone, that when you place these, that you make sure that you're not creating a new osteotomy site, or worse, fracturing that buccal plate of bone, which you've so desperately tried to maintain. Now we're going with our torque limited handpiece, And we're going to drive these to place. I'm just showing you a variation. You could go directly. I could go further with my my finger driver, but they seem to be going in fairly easily, so I'm just going to cut down on the time and see if I can't drive these to place a little quicker. Make sure this is seated on the hex. There you go. What is our speed? 25 to 30 RPM with torque limitation.